You are listening to the Addiction Files, where we discuss evidence-based treatment, clinical pearls, and resources while striving to destigmatize the treatment of addiction in our medical culture and save lives. We are the Addiction Doctors, Dr. Darlene Petersen and Paula Cook. Welcome to the Addiction Files. We are so excited to be back tonight, and we have Brett Heselpoth joining us. And he is actually a care manager in Paula's clinic to talk to us about patient engagement. And this is a topic, like we always talk about, long overdue and something that really for our learning. So I'm going to turn it over to Brett to introduce himself and get us started on this subject.
Hi, I'm Brett Heselpoth. I work as an RN case manager with Dr. Paula Cook at the Moab Regional Recovery Center. I was born and raised in Philadelphia, decided that I wanted to go to nursing school and work in the medical field, probably in high school. And then I ended up going to Gwen and Mercy College, graduated with a bachelor's degree, and I've been in the medical field since 2003. And something else that makes my current employment interesting and different is that I'm a person in long-term recovery. I'm going to be celebrating 14 years of sobriety next month. And I feel like it just gives me, thank you. And I feel like it just gives me a really unique perspective on how to interact with patients and how to keep people engaged.
Oh, I'm so excited you came to be on the podcast, Brett. It's as soon as I met you, I was like, oh, we got to get Brett on the podcast because you're such a special person. And our whole community benefits from having you in it. In fact, you really are kind of a celebrity. Anyone in Southeast Utah knows Brett. He's Employee of the Year for our hospital. And people just really love him here for good reason because you really care about our community and population, and you make such a difference for people. And I have had the pleasure of working with you now for 2 years. And I sit across from you, like hallway wise in my office. And I just have to say, I've learned so much from you professionally just by listening to your interactions with people. You know, just by listening and just thinking, man, that Brett does that so well. Or I've learned and I've tried to acquire some of your skills just observing how you interact with folks. And when I was telling Darlene, okay, let's do this episode, what could we talk about other than just Brett's awesome, let's have him on the podcast? Like, what could we nail it? What could we actually talk about? Darlene had this great idea about, well, what are his skills? Like, why are people, continuing to show up to your program? What are the engagement skills? So I don't know, what do you think? Like, where does your experience bring you to this point? And why is it that, or how do you get people to engage with you?
I think, I don't know, I usually just talk to them on their level. I try to be as non-judgmental as possible. And, I try to listen non-judgmentally because a lot of times we're hearing like really intense stories and just kind of, keeping my composure. Being in recovery, like I know when I talk to patients, usually for any new patients, I kind of give them a rundown of like my history and my professional career. And I can always tell that when I tell somebody I'm in recovery, like they kind of relax, they seem to open up a lot more. And I think it kind of builds a trust with them because they know that I've been through that, through addiction and detox and all that stuff. And I don't know, I just try to be really personable. We get to know all of our patients really, really well. And I have a really good memory. So I think when I, ask somebody about a vacation or something like that, I feel like it's really meaningful to them because they see a lot of medical professionals over the years. And, a lot of it, it's like this power dynamic where you're talking to a doctor and you really have no relationship outside of that. So I think a lot of it's like fostering like a positive relationship. And a lot of it is just leading by example. I run a support group every Friday. It's one thing to tell people I'm in recovery, but like them, watching me run groups and seeing them doing well, I think I lead by example. I don't know if that answers your question fully. I don't know exactly what I do. It just comes naturally, honestly.
Yeah, no, that's good. I mean, I'm interested to know if your approach is to disclose that you're in long-term recovery with every person you encounter, or do you just select to tell people when you feel like it will help build that relationship of trust? Like, what's your approach, and how did you end up doing addiction medicine too? Maybe you could tell us a bit about that.
Oh, for sure. Well, maybe I'll start with your last question. So I was previously dependent on opioids, benzodiazepines, alcohol. Ended up going through treatment in 2010. At the time, I ended up losing my nursing license. I entered. It was the Pennsylvania, I think, peer nurse assistance program. So it's kind of like a drug court program. Was able to get my license back, and when I did, my goal was like get back in the medical field and work in addiction medicine because I wanted to help people. Because people did that for me when I was in treatment. When I first got back into the medical field in 2015, I was pretty selective. It was just people that I had built a rapport with. Over time, though, it's just part of my bio that I tell everybody that comes in the door. And honestly, it's been really advantageous because we've had a lot of patients that come in, and we're a small community. People have been stigmatized by their friends, family, the legal system, the medical system here, and it's really hard for people to trust anybody, especially in the medical field. And yeah, it just feels like it kind of lowers their barriers, and I don't know, people just seem to open up more.
Yeah, it really, well, it does. It works. It really works. And I've seen people just, they tell me all the time, well, I trust Brett because he knows what he's been there and he understands. And from your perspective, what I've noticed as well is that you have a lot of compassion. You're telling me and Darlene that you listen non-judgmentally and you develop a positive relationship. So like those are two principles that I can hear that you really foster, whether intentionally or non-intentionally. The other thing I've noticed that you do is you actually, even though you're really empathetic and non-judgmental, you also are really good with explicitly saying what's right and what's not right. And what I mean by that is you're like, I heard you say you should definitely not do that. Like when people are like, well, I still smoke pot, you're non-judgmental, but you're also really clear with expectations of what a recovery program can look like if you're aiming for sobriety. And I think that's really healthy for our community, especially these days where a lot of people are wondering, is it okay to smoke weed? Or, is it okay if I still drink a little bit? So for people who are aiming for abstinence, I think it's nice to have a role model that's setting some clear kind of guardrails around what long-term recovery can look like, because it can look like a lot of things.
I think Paula brought this up, that this was a real skill that you have, Brett, about just dismantling shame with patients. Like people will come in really dark places, and just your ability to kind of sit and just be with them in that space. And tell me a little bit about that, and particularly also with the groups that you said that you run with them. Like, what particular skill set do you find that you're using working with patients?
Yeah, for sure. So as far as like dismantling shame, most new patients we see are just broken when they walk in the door. And yeah, a lot of it is just listening to them, trying to address their needs like immediately. Because I know how addiction is. If somebody walks in and they're in opioid withdrawal, they don't get medication right away, we might never see them again. So it's a lot just, reassuring them that we're going to help them. One of the positives that came out of it was I'm really good at like reading people and situations. And I don't know, that carries on in recovery. Like I'm just really good at, if somebody's upset, like kind of knowing how to read the situation and kind of what to say to kind of diffuse it and make them feel better. So I don't know, as far as my groups, as far as, skills that I use for that to keep people engaged. I think it's just being positive. We have a core group of people that have been coming to my group probably for the past 2 years since I've been running it. And one thing, besides being positive and enthusiastic every day, it's just being consistent. Like we rarely ever call off my group. And if I can't be there, we always have somebody to replace me. Because consistency is huge, especially with meetings in a small rural town. And then, I've just gotten a lot better at like sharing and public speaking over the years. So I don't know. I think, especially when I run groups, I feel like people feel comfortable there. they're willing to share. And I don't know, it's absolutely amazing, because I feel like that positivity and everything, it rubs off on other people. Because especially in my group, I see this dynamic where, other patients, they're like linking up, becoming friends, and like hanging out outside of, meetings in the recovery center. So yeah, I think it brings connection, which is key to recovery. So a lot of our people, when we see them first, they're isolated, they have no friends, no family that they're talking to. So I think it's kind of a camaraderie, accountability, and yeah, it works.
I think you bring up a really important and interesting point, especially in these rural areas. And Paula had talked about this to me, like, I don't know, several months ago, but you have a unique situation. But I don't think this is unique to just your area, but you'll get a lot of people with using substances, and they'll kind of show up in sometimes these rural areas because they're thinking, well, I'm gonna get away, I'm gonna get off my substances, and they're alienated from their family. Now they're really isolated and they're really in trouble. And that's basically what's walking into your clinic, and you're the first point of contact, which is, I mean, that's a really tall order in the first place. But then it's a really tough situation because you have really limited resources in these rural areas. And I don't think these rural communities get enough credit for how bad the problem really is, and how important that your services are, like that group that you do, like you just talked about, that consistency, and then trying to build that community for people who really don't have much. It's like you said, like part of that process of just building back up friends and a social support. What do you do as far as, and so leading into my other question, like what do you do as far as like boundary setting, like teaching boundary setting, one, like for ourselves in the medical community, boundaries like with patients, which can be really hard in case management, but also like boundaries with like families. Like what's your advice to them when they have somebody who's maybe still not in recovery, still actively using? Like what kind of advice do you have?
Yeah, so we actually just did this last week. We had a patient come in with a family member. Mom was asking me that same exact question, and I basically tell family, you cannot give anybody an active addiction anything that they can use to put towards drugs or alcohol, and that includes like shelter. So if, they're paying their rents, food, anything like that. Because I know, like, from my personal story, I know that things did not change for me until I was completely cut off from everything, and I had no other options left but to try and get sober. So I mean, that's one, and just trying to be non-judgmental about your family member. You know, be loving towards them and willing to help as soon as they're ready to get treatment. But besides that, I mean, you can't give an addict or an alcoholic anything that they can use to proliferate their disease.
So setting a really clear boundary around like enabling, kind of like what
enabling.
Look like.
Yeah, big time. I agree.
Yeah, that's really.
I don't know. Do you have any strategies for setting boundaries with, like, for families?
Oh man, it's so hard, but I like to resort to or refer to Al-Anon and their principles of just reassuring families that they're going to always love this person, and just because they have an active substance use disorder, that it doesn't mean they love them any less, but that they didn't cause this struggle or this problem, and they're not responsible for it. So they didn't cause it, and they're not going to cure it. So I'm stealing this from Al-Anon, right? The 3 C's. They didn't cause it. They're not going to cure it. And they can't control the person. They can't control it either. So they can either make the situation worse or they can try and make it better, but they're not responsible to cure the situation either. So, and I refer people to get some professional, I mean, besides us, we're professionals, but to get like professional peer, like family support, like through Al-Anon or we have a state-run peer advocacy program that provides family support. meetings that are on Zoom and in person in Salt Lake City. So I refer them to those meetings to get some real structured education and support around how to work with their loved one, because it's really complicated. And those of us who have someone in their family with either a mental illness or substance use, it's so complicated because you're doing most of this out of love. I don't think anyone who loves anyone is ever trying to hurt them or make their addiction worse. Even those folks who are really doing harm, like using with their kid or giving them money to go buy drugs so they don't get sick, or going to the liquor store to get alcohol, I don't think they mean to cause harm. So it's just about having those boundaries and then learning about codependency and trying to educate about what is codependency and what's going on with you that you feel like you have to fix this person. So, and that's really tough. That's a tough conversation. And then, like you said, Brett, just demonstrating good, clear boundaries. Like, this is just hurting. This is perpetuating the problem. It's not helping them at this point. But it doesn't necessarily mean that you have to watch them be homeless or, destitute or die. Either there are treatment options, and that's what we're here for, right? That's what we do, is try and help people get the help that they need.
Yeah.
Last question on this, Brett.
Yeah.
What do you do? Because I think this goes frequently to our support staff, gets this more than I think even like Paula and I do. What do you do about some of these really enabling family members? Like, because they're sometimes coming and sometimes interfering with your care as the case manager. Like, how do you navigate that? That's a really hard role.
Yeah, dealing with families is very difficult. And we actually at our clinic, I mean, families do come in, but it's not all the time that they come in and there needs to be some kind of intervention. But I don't like, for example, last week, like I pulled this patient's mother into my office and spoke with her about, it was a lot about just treatment options and like what she should and shouldn't do. Yeah, dealing with families is really hard. And, especially here more than in Pennsylvania where I was working, like the substance use is just intergenerational. So we see families where, there's the 15-year-olds using, mom and dad, grandparents are using. So it's really hard and people are really sick. But it's hard. I mean, we offer treatment to anybody, especially if parents are using and things like that. We're happy to see anybody, but it's really, really hard. But, we offer, like Paula said, we can refer people to Al-Anon. We offer groups to anybody that wants to come into our clinic and do support groups. But it's really hard. And it just goes back to being non-judgmental, using non-stigmatizing words and phrases, and just keeping them engaged, which I think we do a really good job at our clinic.
When you were talking, and Darlene, when you were asking those questions, so we've been developing a collaborative care model for our alcohol use disorder patients. And so I've been, reading about it and reading the research and watching some webinars and realizing that the key principles of collaborative care models, which is, where you have a registry of patients with a certain diagnosis that's then managed mostly by a care manager with either a primary care doctor, or in our case, it would be an addiction medicine with maybe consultative help from a psychiatrist or another specialist. And in so doing, you watch treatment outcomes improve, and hopefully you keep people engaged and you have overall improvement, right? As well, not only in individual health, but in the population health and the health of your whole cohort. And as I've been watching this, I've realized that not to like toot our own horns, but I think we do this really well. And I think you do this well already. And it has to do with two things that I could identify right away. And one is one thing you already mentioned, Brett, which is low barrier access to treatment. And that you as a case manager really advocate for people to get them treatment right then and there. Even if like I'm completely busy, you're always like, hey, let's do this. Like, let's get this person treated right away. And you're a really good advocate for that. And that philosophy is so healthy because you have to have the whole team that believes in that philosophy, that it's low barrier, low access to treatment, or high access to treatment, I should say. Because if you only have one person in a clinic who believes that and everyone else is blocking it, then people are not going to get treated appropriately. So I thought that was really good. And the other thing is you mentioned it, but it's about consistency and just getting back with people. And you're very good at that. And that's a principle that I think people doing addiction medicine, we could all be better at, is just really engaging with people right then and there, and then consistently following up, never missing groups, never canceling, don't cancel appointments, don't cancel therapy, just always being there and being reliable. And I attended, Darlene, I'm trying to think if you were with me. We were somewhere at one of the conferences and we went to an advocacy meeting. Actually, I think it was the harm reduction conference in Puerto Rico. And this group was talking about how they got safe consumption sites passed in New York State. And they were discussing how they got that to occur, because it's really difficult on a legislative level. It's the only state that's had that work over time that haven't been dismantled. And one thing he said is like, we had user groups. So we invited people with active substance use to a group every week so we could talk to them about what it meant to have a safe consumption site and what harm reduction needed to look like in our community. And what we heard from them is we had to show up because they're used to everyone just disregarding them as lower members of society. And the medical system really, really is the worst at that. We stigmatize and mistreat people with substance use disorder. So not canceling, showing up, being on time, like having a level of professional ethics and etiquette is even more important, because people are used to being treated so badly that when you do show up and are consistent and follow up and have low access to care, people realize that you're trustworthy. So I was saying a lot of words to say that the cohort really buys into this model that I can trust you guys. You're there when I need you. You follow through with what you say you're going to. You don't cancel on me, and you're always consistent. Your messaging is consistent.
One of the keys to that I was just going to mention, which is, it seems pretty silly, but just answering my phone or calling people back the same day, like, goes a long way. And a big thing is just staying and communicate. Like if somebody has labs done, like literally calling them next day and just going over their lab results or prescription refills. Like people really, really, really appreciate that. And it goes a long way because, people keep calling me every day. So it's working and they keep coming back in.
I mean, those are important principles, though, for case management. Is you'll hear on some of these phone lines that you'll call in, it's 72 hours, don't expect a phone, and people will say, I called my doctor's office and nobody called me back for days. And we're like, that's not an acceptable level of care. Like, we want to make sure, we have within reason, because we're human beings, but we want to make sure that we have the appropriate staffing to meet the patients that we're taking care of. But you want to be able to have that connection. And that's what we're really talking about, is do we make that connection with them and then keep our agreements with them?
Oh, I love that. So that's integrity. That is integrity. And that's what it is, right? Is just doing what you say you would do. Like, I'll call you back, and you do,
Yep.
So that's the follow through part. So I think it's been kind of cool. So you talked about like your initial face-to-face kind of contact with people and what that's like and what works, and then what works ongoing to keep people engaged, and then how we kind of can key family into also staying engaged. And there was something I wanted to just loop back on that I've been thinking of, and just go back to like initial patient engagement, if that's okay. Because I've been reading, and Darlene knows about this because I talk to her about this like almost every day, but I've been reading Brene Brown's book, Atlas of the Heart, and it's just been
amazing.
My mind. Yeah, it's so good. And she, just to quote her, she has a chapter on shame and guilt. And she says, shame can't survive being spoken because it has three components to it. In order for shame to thrive in people, it needs secrecy, silence, and judgment. And when I was listening, well, actually, I'm not reading her book, I'm listening to it on Audible. But when she was saying that, I was like, that's why I think you're so good at what you do. And that's why, too, like our peer support coaches that we work with in our community are so amazing, because those three things dissolve in the face of peer support staff and people with lived experience. There's no secrecy, like there doesn't need to be, because it's like it's an open book, right? You can say, look, I've been there. And the silence can be broken because you know the words to say. Like we're working with an organization like an anti-trafficking organization. And sometimes I don't even have the context to know what to say to someone. So I'm silent and they're silent back to me. But someone with lived experience knows exactly how they feel, what they need. Do they need food? And then judgment. So secrecy, silence, and judgment. Judgment is not there because, why would you judge someone? We've been there, and also we're just here to support. So I was just thinking about that. I think that seems to be, well, obviously Brene Brown does a lot of sociological research on what shame is and how to deconstruct it, but I think that's what seems to be really working with patient engagement in the beginning, and then integrity and follow-up and consistency seems to work on the back end.
Yeah, and I think just like helping people, like just doing general case management, like a big part of my job is helping people apply for Medicaid, and referring them to outside resources, getting them plugged in with like a primary care doctor. And I feel like people really appreciate that. And a lot of people we see, they're unhoused, they're unemployed, they don't have any family in the area, so they don't know what to do. They've been using, so they don't even know how to apply for a job or get their driver's license back. It's just a lot of little stuff like that I feel like that keeps people coming back to the clinic because we are so helpful.
So do you think, like in terms of advocating, I think that our clinic and our program was started by just such an amazing person, right? Dr. Lauren Preston. She was lucky enough to find you, and you started working together as a duo. And how can we advocate to people who are listening to this podcast who may be practicing addiction medicine or developing teams to, one, engage and hire people to do case management, and then two, to employ and engage people who have lived experience and are in long-term recovery?
Yeah, for sure. So the organization I worked for before I moved out to Moab from Philadelphia, they always like to hire anybody in recovery. And I feel like people in recovery are invaluable because, we have lived experience with like how to read people, how to judge situations. Kind of goes back to what I was talking about earlier. But we're extremely hardworking. We have integrity, accountability, and anybody that can survive an addiction is a survivor. I think they're, a lot of us die through our addiction. So if you can survive an addiction, you can survive anything and thrive in any kind of situation. And, working as a case manager now, if we did not have a case manager, we would just be seeing patients and getting them out the door. But, I think because I help people link to, other healthcare providers, other resources, like hopefully there's a direct correlation between like, more people are working, more people are housed. People are having less legal issues. People are having less physical complications or mental health complications. So, and I don't do all that on my own. I think it's more like providing wraparound services and care and bridging people to other services that's really helpful for the community as a whole.
I know from studies coming out from like the housing first movement that people who get housing, regardless of whether they use drugs or not, end up using less and don't die as much and end up getting employed. It makes so much sense. Darlene, you ran your own clinic for decades. Did you have a case manager? And what do you think as someone who's like run her own medicine and primary care practice?
I did not have like a case manager, but I had way over functioning like medical assistants that did and even my front office who would do much of this work. Now being in a setting where I have an RN case manager, and then I have actually a social worker to do much of that. It's amazing having that support. Like when you can a patient comes in and you can just be like, okay, I'm going to have you meet with this person and you're going to meet with this person. It just like takes such a load off, and you can actually offer them those resources where it was kind of fragmented. Like in the private sector, it is really hard because, where you don't have a dedicated person who can just sit down and say, okay, I've got all this pulled up. We can just sit down. Where we were just kind of, well, we'll refer you here. We know where we can get you referred. But when you have somebody like what Brett's talking about, they come in an acute crisis, you've got really one shot, right? You've got one shot to be able to get them really stable. And that's what's really hard, you know? And I honestly couldn't take care of patients as sick as what you take care of in that kind of setting. And so I feel like in a lot of areas, we really are not capturing, a lot of people aren't getting the care that they need because we just don't have the resources out there. We aren't funding it. That's what's hard.
Right. We're not funding it. And what's been really great from my experience, this is the first time in my career that I've had the chance to work with a nurse case manager. I've worked with a case manager before, but not someone who's got a nursing background. And it's just so nice because Brett comes with this medical background too. So he understands the medications and, in fact, I think, often know more about these medications than I do. You're like school.
I don't know about that, but
you're like, well, but, someone that has a health background, and I think case managers can come from like a social work background or a nursing background, or just like a social services background. But in addiction medicine, it's just been really great to have an LCSW on our team and a nurse case manager. It's been really, really effective. And just looking at like the data or what's out there in terms of patient engagement strategies, there's recommendations for like what are pre-visit engagement strategies, in-visit, post-visit, and ongoing. And I think we've hit most of them, except maybe like what do we do for ongoing patient engagement in terms of feedback. And I don't know if we do anything very formally with that in our clinic, but because we come from a very small population, I think the feedback's like instant and we would hear about it. But I think in bigger communities, it's really important to have ongoing patient feedback so that you could keep your patients engaged about what's not going well. Like I think about myself as a patient, I don't have a substance use disorder, but for other vulnerable situations or for family members who do, there are things that can be so sensitive that if something doesn't go well with an encounter with the health system, it's so easy to be like, I don't want to go back there. I don't like those guys. I don't trust them. They're not treating you well or don't understand you. So to have constant feedback where you can give and say, this isn't working and can we try this? And have the organization actually hear you and make changes is really important as well.
That's great advice and something just to keep aware of, that not these, I really hate these like pre-blanketed surveys that sometimes we'll just send out that aren't very meaningful. But that feedback that patients just give us in the room, that sometimes like, hey, this happened, this isn't going well. And then being able to, when you have these smaller clinics, taking that feedback and just digesting that, is this a process improvement? Is this a personnel change that we need to make? Or is this just a personality, like, this person maybe is never going to get, I'm not ever going to be able to make them happy.
We understand that.
That's how I would always break it down.
Brett, I have one more question for you. And
sure.
That is, what do you, from someone who went through, recovery yourself, what do you wish addiction medicine or primary care or emergency medicine or any medical provider or behavioral health provider knew? Like, what do you wish they knew about you when you were going through it and could have done better?
For sure. Well, just sort of a normal, nice human being. And, I definitely felt stigmatized at times when I was using. And I'll give you a quick story. Right before I got sober, I think this was in September of 2010, I was in a car accident and I ended up in the emergency room and I was really sick. I was withdrawing, and I asked a social worker if there's any way I can get Suboxone or a dose of methadone or anything to help me. And out in the hallway, she was talking to the doctor, and I heard her say, "So such and such, this guy's a junkie, and he's asking for meds." And after that, I was already scheduled to go to treatment later that day, but I don't know. After that, like I didn't want to go to the doctor. I mean, it was years. I just got a primary care doc after 13 years, but yeah, just, and listen to people, even if somebody has an addiction, I mean, they're still living their lives. They have families, friends, children, parents. And, yeah. And I will say, anybody dealing with an addiction, like I did not want to be addicted. I got to a point where I was just done with it. I just didn't know how to get out of it. And, I feel like a lot of, friends and family that didn't fully understand addiction, I feel like they thought it was more of like a personal choice, and I was just, just disregarding them. But yeah, just treat people like you would treat anybody else, like you would treat a family member, because we're all normal human beings. Just, we're sick and we just need help.
I think, Brett, you bring up such an important point, is paying attention to our entire care team. And because every person, like you said, that you interact. And so it's like that social work that you interacted, and what a negative impact that had on you. And so sometimes we may pay attention, like I may be a really caring, compassionate physician, but if the secretary that's checking you in is very stigmatizing in the way that they treat you when you walk into the clinic, well, you're never going to come back to this physician who could have maybe helped you. And like you said, you were like, I was ready for treatment, but this really put a damper on it, and I needed health care. And how many times does that happen, right? From those negative interactions, and we don't always pay attention to that, every person in that chain that you touch in that healthcare team.
Love that. That's so good. That's been pretty inspirational to me, and I'm excited to make some changes in my own practice after today. And I really want to thank you for joining us, Britt. Thank you for the work that you do and being so courageous and vulnerable. And it was just International Overdose Awareness Day all over the world, and we had it in our community, and you spoke at our one. And as I was leaving, I was talking to my husband, and we were just saying, nowhere else in the world do people tell on themselves like they do in recovery. Like, people in recovery from substance use disorder, they're always telling on themselves and fessing up to what they did. And like the rest of us we just have all these things that we did that we like. I stole my brother's calculator when I was a kid, and I still don't think I told him, I mean, that's a really
well, you just did now, Paula.
I hid it under the bed, and I mean, that's such a silly example, but I just have a lot of admiration for people who've worked recovery, and they're really honest and have made amends in ways that those of us who haven't struggled with a substance use disorder haven't done that personal work. So I really honor you and everyone else in recovery who's done that work and is doing that work.
Thank you so much, Paula. Well, it's an honor to work with you every day. So I'm super blessed.
Thank you so much, Brett, for joining us in your time.
Yeah. Thank you very much.
Until next time. Hey, check us out at theaddictionfiles.com or email us at theaddictionfiles@gmail.com. Thank you so much to Ricky Valades for use of his song Awake. Check him out at rickyvalades.com.
Podcasts are for entertainment and education purposes only. Hosts and guests are not responsible for any harm caused by information obtained from this source. As each person is unique, you're advised to seek the advice of your own healthcare professional to treat any medical conditions you may be having. Opinions expressed on this show are those of the Addiction Files and not of our respective employers.